So today we are going to discuss a very important topic, hypokalemia. So potassium is a very important ion of human body. Majority of the potassium is present intracellularly, whereas the small amount is present extracellularly. Majority of body potassium is present in the muscles, whereas most of the extracellular potassium is present in the bones. Less than 1% of the total body potassium is present in the plasma. The recommended daily allowance of potassium is 1 to 2 milliequivalent per kg. Now, before discussing hypokalemia, we should know few things about the potassium metabolism. One thing is, as I told you, that majority of the body potassium is present intracellularly, and the concentration is 150 milliequivalent per liter. The potassium is needed for the resting membrane to maintain the resting membrane the excitability of the nerves and the muscles. So what happens is, this is a cell, and this is the intracellular space, and this is the extracellular space. As I told you, the intracellular, the concentration of potassium is 150 milliequivalent per liter. So majority of the potassium is present inside the cells, and a small amount is present extracellularly. This is needed to maintain the resting membrane potential, which is around minus 70 millivolt in the nerves and around minus 90 millivolts in all other cells. So to maintain the resting membrane potential, we have three efficient mechanisms working. First is this sodium 3 sodium and 2 sodium pump, which pumps out the 3 sodium outside and pumps in the 2 potassium inside. And then we have the potassium leak channels, through which the potassium can go out as well as go in following the concentration gradient. As you know, the majority of potassium is intracellularly, so it goes out. So as the potassium goes out, it carries the positive charge outside, so inside becomes negative and the outside is comparatively positive. So when this concentration gradient is balanced out, that time there is no movement of potassium inside and outside of the cell. That is known as the resting membrane potential. It is a steady electric potential across the cell membrane when the cell is not getting excited. Now, the other thing that you should know about this, we need the resting membrane potential so that it maintains the excitability of the nerves and the muscles, and it helps in generating the action potential so that the action potential can be generated in various cells. The one thing that you should remember is the transcellular shift. The triggers which can lead to the potassium going inside the cells and leading to the reduced potassium in the plasma. For this, you should remember these three letters A, B, I. A stands for alkalemia, which means alkalosis, metabolic or respiratory alkalosis. Then second is the beta agonist, and the third is the insulin. So these three are the factors which lead to the transcellular shift of the potassium from inside the cells and can lead to the hypokalemia. Now there is another mechanism that you should know before we go on to the main topic, is the RAS mechanism. So for the RAS mechanism to get activated, we need 3 triggers. These triggers can be reduced renal perfusion, as can happen in the dehydration or shock state, or reduced sodium chloride delivery to distal tubule, where it is sensed by the macula densa. And third is the beta-1 stimulation. Now all these three triggers lead to this is sensed by the juxtaglomerular apparatus, through which there is a release of renin. Now what does renin do? Renin is an enzyme which leads to the conversion of angiotensinogen to angiotensin 1. Through pulmonary capillaries, we have the another enzyme, angiotensinogen converting enzyme, which converts the angiotensinogen 1 to angiotensinogen 2, which again leads to the increase in the aldosterone production by adrenal. Now this aldosterone is important. What does it lead to? It leads to increased sodium reabsorption, increased potassium secretion, especially in the collecting ducts, and increased hydrogen ion secretions. Now, why is it important in hypokalemia? As you can see, there is potassium secretion and this hydrogen ion secretion, which can lead to hypokalemia plus metabolic alkalosis. Now we go on to our main topic, which is approach to hypokalemia. So there are three main causes of hypokalemia. One is the spurious lab value, second is the transcellular shift, and the most important is when the total body potassium is low. So the spurious or the false hypokalemia can be seen in cases of high TLC count, as in leukemia patients. When there is high TLC counts, which what happens is, when you leave the sample from a patient with high TLC, like as in case of leukemic patient, there is the potassium enters the cells and leads to the false hypokalemia. The second cause is the transcellular shift, which can be transcellular shift can be there because of these three factors: ABI, which I have discussed previously, alkalemia, beta agonist, and the insulin. Now, apart from this, there are three other causes, which are the hypokalemic periodic paralysis, now in the transcellular shift we have the ABI, which I have already discussed, and then we have the hypokalemic periodic paralysis, which is an autosomal dominant condition. This is a condition in which the acute setting of hypokalemia occurs due to the shift of potassium from extracellular to the intracellular space. It is an autosomal dominant condition. Other one is the thyrotoxic periodic paralysis, which is a rare manifestation of hyperthyroidism, in which there is acute entry of potassium intracellularly. And third is the refeeding syndrome. Now, apart from these six causes, we have some rare causes. If you want to remember them, you can remember, like theophylline overdose, barium intoxication, cesium chloride ingestion, which is a homeopathic cancer remedy, and third is the toluene intoxication, which happens in people who do the glue or paint sniffing. So these six are important causes, and these three, if you want to remember, you can remember. Now, after I have seen you have seen the ruled out the spurious cause and the transcellular shift, then in the transcellular shift the total body potassium is normal. Only because of the transcellular shift of potassium from extracellular to intracellular space, there is hypokalemia. Whereas in cases with reduced total body potassium, there is total body potassium is lost. Now we'll discuss it in detail. Reduced total body potassium can be due to the insufficient intake or excessive loss. In insufficient intake, only one cause is there, which is anorexia nervosa, where the patient is not taking anything. Now, excessive losses. Now, the losses can be renal losses or extra-renal losses. In extra-renal losses, the extra-renal losses can be due to the minor cause like sweating. Now, if there is too much sweating, for example, in case of vigorous exercise, someone is doing vigorous exercise in hot climate, it can lead to hypokalemia. Now, the more common cause is GI losses. GI losses can occur via diarrhea. So, in the diarrheal stools not only contain potassium, but they also contains bicarbonate ions. So, there is hypokalemia plus metabolic acidosis is there due to the bicarbonate loss. Other common cause is laxative abuse, in which there is normal acid-base balance. Third one is using the potassium binding resins like caxylate. Or sodium polystyrene sulfonate. And third is clay ingestion, which happens in cases of pica. When the person takes the clay, there is excessive loss of potassium in the stools. How will you differentiate whether the loss is extrarenal or renal loss? We look at one thing called transtubular potassium gradient. If it is less than or equal to 4, then we think then it is extrarenal loss, and whereas if it is more than 4, then renal losses. Or urinary potassium concentration. If it is less than or equal to 15 milliequivalent per liter, then extrarenal losses, and if it is more than 15 milliequivalent per liter, then renal losses are there. In renal potassium wasting, after we know that due to the renal causes the potassium is getting wasted, we have to look at the ABG of the patient. We have three scenarios in this: variable acid-base status. Second is the metabolic acidosis, and third one and the most important one is the metabolic alkalosis, which we are going to discuss in detail. In the variable acid-base status, we have four important causes. One is the magnesium deficiency. Second is the saline diuresis. Third one, use of antibiotics like aminoglycosides or amphotericin B. And fourth is the polyuric phases or polyuric disorders like polyuria after post-obstruction or post-obstructive diuresis. Now in the metabolic acidosis, we have some very important causes like renal tubular acidosis, type 1 and type 2. Second is the decay. Most of the patients which present with decay have normal total body potassium due to the transcellular shift due to the insulin deficiency and acidosis. But in these patients there is the total body potassium is low due to the urinary wasting of potassium because of osmotic diuresis. So total body potassium is low. So the hypokalemia can get aggravated when you start the insulin therapy, which further leads to transcellular shift of potassium from extracellular to intracellular, as the body is already deficient in potassium. Third important cause is ureterosigmoid diversion. It is a urinary diversion procedure in which we connect the ureter to the sigmoid colon. So what happens is there is increased sodium reabsorption and increased chloride reabsorption in exchange of the bicarbonate, which leads to the hyperchloremic metabolic acidosis, which is normal anion gap metabolic acidosis. And fourth one is carbonic anhydrase inhibitors like acetazolamide. Now, when we know that the child is having metabolic alkalosis, so with hypokalemia, so there is the increased metabolic alkalosis due to the increased hydrogen ion loss, and reduced potassium can be due to the GI losses or due to the renal losses. So to differentiate between them, we look at the urinary chloride concentration. So if your urinary chloride is equal to or less than 15 milliequivalent per liter, it implies that there is a chloride depletion and it is a volume depleted state, which leads to the secondary RAS activation. Secondary RAS activation leads to increased aldosterone production, which leads to increased hydrogen ion and potassium ion secretion, which leads to metabolic alkalosis and hypokalemia. And as it is a volume depleted state, so what kidney tries to do, it tries to retain the potassium, and this condition will respond to the saline. It is saline responsive hypokalemia. So the causes of metabolic alkalosis with urinary chloride less than or equal to 15 are four important causes. First is the GI losses. These GI losses can be in the form of emesis or NG suction. What happens is the GI loss of hydrogen chloride acid leads to the metabolic alkalosis, whereas the GI secretions contain minimal potassium around 10 milliequivalent per liter, so it does not cause significant hypokalemia. Hypokalemia occurs due to the volume depletion and secondary RAS activation. So GI loss of hydrogen chloride acid lead to the metabolic alkalosis, and due to the GI losses there is volume depletion, which leads to secondary RAS activation, which leads to the hypokalemia and further aggravates the metabolic alkalosis. Second important cause is cystic fibrosis, in which there is chloride loss in the sweat. Third is the post-hypercapnic state. So what happens is, in cases of hypercapnia, we have respiratory acidosis. So in compensation, there is increased bicarbonate reabsorption and simultaneously increased chloride secretion. So when the respiratory acidosis gets corrected, there is alkalosis, and depleted chloride state leads to the volume depletion and secondary RAS activation. And the fourth important cause is post-diuretic use. Why post-diuretic? Because during the diuretic use, there is increased chloride in the urine, but after you stop the diuretic use, there is a reduced chloride content in the body, and which leads to this metabolic alkalosis with hypokalemia, with reduced urinary chloride. Now, when the urinary chloride is high, more than 15, with hypokalemia and metabolic alkalosis, now it can happen in two conditions. One, the patient can have normal or low BP, or the patient is having high BP. So if the patient is having normal or low BP, it means that the kidney is losing the potassium, not due to the mineralocorticoid excess, because if there is mineralocorticoid excess, it leads to the hypertensive state, which is the second one. But the kidney is losing chloride due to the tubular damage. In this, we have two very important causes: Bartter and Gentleman syndrome. For Bartter and Gentleman, you should remember one more thing. There is hypercalciuria and Bartter syndrome, and there is hypocalcemia, which can lead to nephrocalcinosis. Whereas in Gentleman, there is hypomagnesemia. Other cause is recent diuretic use. Now for high BP, we have another two conditions. As you have studied, as I have already told about the RAS mechanism, there can be two conditions: renin is high or renin is low. So first condition, when the renin is high, which leads to activation of RAS mechanism, it includes renal parenchymal disease, renovascular disease like renal artery stenosis, renal tumors, renal compression syndromes, pheochromocytoma. Whereas the condition with low renin levels, it includes increased aldosterone, conditions with increased aldosterone levels. This includes primary hyperaldosteronism, glucocorticoid remediable aldosteronism, familial hyperaldosteronism. Second one is there is reduced aldosterone level. There is excess of other compounds which mimics the which has the mineralocorticoid action apart from the aldosterone. It can happen in case of congenital adrenal hyperplasia as 11-beta hydroxylase deficiency and 17-alpha hydroxylase deficiency. In both of these conditions, there is increased deoxycorticosterone level, which has the mineralocorticoid activity. Another common cause is apparent mineralocorticoid excess. In this condition, there is a deficiency of enzyme 11-beta hydroxysteroid dehydrogenase. So what is the action of this enzyme? This enzyme converts the cortisol into cortisone in the kidney. So if this enzyme is deficient, this conversion cannot happen, and this cortisol has the mineralocorticoid activity, and it activates the mineralocorticoid receptor, which leads to the manifestations of mineralocorticoid excess without raised aldosterone level. It is an autosomal recessive condition. Now, for the treatment, we can give spironolactone, which will block the mineralocorticoid receptor. There is the acquired form of this, which is seen in people with licorice ingestion. Another important cause is Liddle syndrome. It is an autosomal dominant condition. There is gain of function mutation in the ENaC, epithelial sodium channels, in the collecting duct. Now we can block, for the treatment we can block these channels, and the drugs that can block these channels are amiloride and triamcinolone. Another cause is mineralocorticoid receptor activating mutation. Now, to remember any topic, you should try to consolidate that topic in a single sheet, which you can revise later on. So I have made a diagram, a revision diagram, in which we will revise all those causes which I have discussed. So hypokalemia, in cases of hypokalemia, first thing you should do is to rule out spurious hypokalemia via ruling out the high TLC count and the late processing of the sample. Now after that, you see if there are any causes of transcellular shift present. We have discussed the ABI, alkalemia, beta agonist or insulin. After that, we have the thyrotoxic periodic paralysis and hypokalemic periodic paralysis. Then we have the refeeding syndrome, and the less important causes include the toluene ingestion, theophylline over intoxication, and barium ingestion. After that, we look at if the total body potassium is low, we look at the extrarenal losses. In the extrarenal losses, sweating is one of the cause, and the more important one are the GI losses, which can happen in diarrhea, laxative abuse, potassium binding reagents like sodium polystyrene sulfonate or K-oxalate ingestion, and clay ingestion. Now, in the renal losses, we again divided based on the ABG of the patient. For variable acid base balance, we have the magnesium deficiency, drugs like aminoglycosides and amphotericin B, and polyuric disorders. For metabolic acidosis, we have the renal tubular acidosis type 1 and type 2, diabetic ketoacidosis, carbonic anhydrase inhibitors, and uretrosigmoidostomy. In the metabolic alkalosis, we look at the urinary chloride levels. If the urinary chloride level is less than or equal to 15, then it can be in GI losses, as in emesis and vomiting and NG suction. Second one is cystic fibrosis. Third one is post-hypercapnia. And fourth one is post-diuretic abuse. If the urinary chloride concentration is more than 15 milliequivalent per liter, then we look at the BP of the patient. If the BP is low or normal, then two important causes are Bartter and Gitelman syndrome. If the BP is high, then we look at the renin level. If the renin level is high, then it can be due to the renal parenchymal disease and renovascular disease. And if the renin level is low, then we look at the aldosterone level. If aldosterone levels are high, then it includes the primary hyperaldosteronism, familial hyperaldosteronism, and glucocorticoid remediable hyperaldosteronism. And then if the aldosterone levels are low, then it can be due to the apparent mineralocorticoid excess, congenital adrenal hyperplasia, Liddle syndrome. That is it. Now in the second part, we'll discuss the clinical features, diagnosis and treatment of hypokalemia. Thank you.